This is Michael Smith of MedPage Today. I'm in Phoenix at the annual meeting of the American College of Allergy, Asthma, and Immunology. And with me today are Dr. John Oppenheimer and Dr. Galen Marshall, both members of the program committee for this meeting. Gentlemen, welcome back to MedPage Today.
It's a pleasure.
Let's talk a little bit about the themes of this meeting. And Dr. Marshall, you actually have a sort of an anniversary to talk about.
That's right. 2011 is the 100-year anniversary of the first report in the Lancet about how allergy shots work, and that they do work. Dr. Noon published this 100 years ago, and this meeting is sort of the kickoff of that anniversary in the allergy field around the world. And the really important thing that we're looking at in this meeting is where we've been from 100 years ago, where we are right now compared to where we started, and where we'll go as we move into the next 100 years to improve the effectiveness and the safety of allergy shots for our patients.
Super. Dr. Oppenheimer, what sorts of things are we seeing in terms of, people are still getting allergy shots, surely?
Well, we're beginning to understand immunologically the language, the mechanisms by which it works. It's hard to believe, as Dr. Marshall points out, we're really doing basically the same thing we did 100 years ago. But with our understanding comes ways to make it more effective, hopefully make it more safe, whether it be by using an alternative route sublingually versus injection, or by adding immunologic motifs to help make it more immunogenic but possibly less allergic.
I see. Dr. Marshall, there is a lot at this meeting on the sublingual route, which is much more commonly used, I think, in Europe.
Right now, it's been used a lot in the Western Hemisphere in various forms over the year. People have used what they call allergy drops a lot for quite a while. But that's very different from the sublingual immune therapy that the Europeans have worked out and done over the last decade to 15 years. And it is being evaluated very carefully in America right now, and there are clinical trials going on, so it's in its way of moving from Europe across the ocean to North America.
I guess the key advantage of that is you don't have to have a shot.
Well, and that's not trivial, particularly for children. Particularly, one of the things we know that is a progress note in allergy shots is that the higher the dose that can be given, the better it is. All things being equal, that's a fair statement. But the higher the dose that you give, the more dangerous it potentially is in terms of side effects. So there's a cost associated with giving the injection, having the individual wait in the office, and so on. There's clearly a theoretical advantage to not only being able to avoid a shot by having it under the tongue, but with some of the safety data that the Europeans are showing us, it may well be safe enough to give to most patients for home use. That would be a big new step for us in immunotherapy.
Okay, there is, and let me just shift gears a bit, there is, of course, at this meeting, as always, a great deal of information about asthma. Dr. Oppenheimer, are we seeing sort of progress on understanding who gets asthma, what sorts of disease they get?
I think we are, but I think the greatest thrust of this movie has been this meeting has been the fact that we're moving towards understanding the fact that asthma is not one illness. It's many, many illnesses, and we're using a buzzword of phenotype. We're trying to figure out what characteristics of asthmatics may predispose them to respond or not respond to a specific therapy. Up until now, what we would do is when somebody had asthma, we would give them a specific therapy. If it didn't work, we would just increase that specific therapy. And we're learning that that is the wrong way to do it. We have to think about other modalities.
I see. How are we in terms of reducing the burden of the disease? I think there's a paper here suggesting that really, on a population basis, people are not being treated well at all.
There's an abstract at this meeting that shows that, unfortunately, if we look at control, the majority of our asthmatics are not in good control. It speaks to the fact that we need to do a better job.
Mm-hmm. Dr. Marshall, maybe you can sort of fill us in on that. Why are we missing patients? Are they not getting the right medications? Where does this disconnect lie?
Well, I think you ask a very important question that is being addressed in social research, in biological research, and in clinical research. We're not sure the answer, but we know that there's several different areas where it could be. Most people do what they need to do to make themselves feel better. One of the things we realize is that asthma patients in particular, true of all chronic diseases, but asthma in particular, is that if their changes are very small, if you don't feel that much worse today than you did yesterday, well, you're probably not going to change anything you're doing. If you don't feel that much worse tomorrow than you did today, even though you're getting worse by the day, you may not perceive it. And so what we're understanding is that many of our asthma patients are what we call poor perceivers. They do not realize how compromised their lungs are. And so many of these medicines are expensive. Many of them have side effects. Many of them are not easy to use correctly. And so therefore they sort of say, well, I don't feel that much difference, so it really doesn't matter. Another is, and that's really our burden as providers, we've not done the job that we need to do in educating our patients to understand that they don't want to wait till they need it. It's like if I knew I was going to have a car accident tonight and didn't have car insurance, I'd buy it this afternoon. We keep insurance because we don't know when something untoward is going to happen. Many of these medicines, particularly the group that we call controllers, are designed to be just that, insurance policy to keep our patients from getting ill. If we can communicate that more effectively, I believe we'll see the adherence to our medical regimens improve for them.
Let me ask both of you this question. Is asthma regarded as a serious disease among both the public and physicians? Dr. Oppenheimer?
I think that, as Dr. Marshall points out, the public perceives it as serious when they're in the midst of an exacerbation. Otherwise, it really is part of their daily living. They don't see it as being deleterious. For those that have very labile asthma, they may see this more frequent, but the majority of people aren't having asthma symptoms all that frequently. So between exacerbations, they often try to forget or suppress it from being part of their daily living. I think from the standpoint of physicians, likewise, most people come in, if you ask them, how are you feeling, and they say, I feel great, that's the end of their conversation. So we're also learning, this meeting reinforcing it, that it's important to really determine, is control to the level that it ought to be. If you simply ask, are you in control to the patient, it's not going to be enough.
Mm-hmm. Let me ask you one final question. There is a presentation here, and last year there were several presentations, but the procedure has now been approved, and that's bronchial thermoplasty. Is that ready for prime time, Dr. Marshall?
I think it depends who you are asking that question to. If we're talking about the patient population at large for asthma, I would say no, it's not ready for prime time. And the reason I say that is that if this procedure takes a person who is under control of their asthma and allows them to reduce medicine to maintain control, this is a procedure that produces permanent changes in the airways. That we don't have enough data for a long enough period of time to determine whether that's a good idea or not. On the other hand, remember that there is a subgroup of asthma patients that no matter what we've tried to do for them, no matter what medicines we've tried to give to them, we've really not been able to control their disease. And we know that some of these medicines and having to be on them and this lack of control are both well-defined risk factors for death from asthma. Now the risk of that gets high enough that a more radical procedure like thermoplasty, which creates permanent changes in the lung, are much more rational because you're now talking about a population who's very likely to die of their disease. You're now changing that dynamic. That's a very good idea for me in the short term, but that same patient population will teach us over time, now that they live then 3 years from now, 5 years from now, 10 years from now, are there any unanticipated side effects of this procedure in that patient population that tells us that's not something we want to bring into the less severe illness, or does it show a safety that says it's okay? That's done in other areas, oncology, cardiology, and so on. This is perfectly rational to do. If you say, well, you're experimenting in those patients, absolutely not. You're doing something that is fairly radical by anyone's description, but it is keeping them, it is lowering their risk of dying. If they're dead, it doesn't matter what the side effect is 10 years from now. So it is a double, it's a double benefit. It's a benefit to them, and it will be a benefit to us as we learn from their experience in terms of its long-standing safety. There's no way that the people who develop this therapy can know that simply because it hasn't been that long that it's been around.
Passionate about the subject. Gentlemen, thank you both for joining us today.
It's always a pleasure.
Thank you.
In Phoenix, I'm Michael Smith, MedPage Today.